Good morning, everyone. It is Wednesday, February 9th. It is 9:04, and it's our first Benefits Committee meeting for 2022. Thank you all for coming. Thank you all for joining online. Sean is here. Sean Fleming from the Garing Group is here to discuss our claims experience and some other discussions that we need to have to begin the year, and then there'll be time for some questions at the end. So Sean, go ahead and take it away.
Thanks. Well, good morning, everybody. Happy 2022, I think. A little bit of more of the same when it comes to COVID, but we wanted to get everybody together, give you a little recap on how the plan finished on the end of last year, and talk about some of the discussions that we've been having for the upcoming year. Obviously, we're only in February, so we have a lot of this year left. But do want to look at how things are going and talk a little bit about globally kind of what we're seeing in the market, and how that's impacting the city of Clearwater, and kind of talk about a couple different timelines with that. Just give you guys a high-level overview of the plan and what's going on. So before I dive in, does anybody have any questions or anything I want to start with? Good. All right. Well, if you guys want to open up your packet here to the page behind the agenda, we have the total claims experience for the plan year for 2021, which is our calendar year 2021. We have this is your first meeting, is that correct, sir? All right. I don't know if you have anyone else, so I'll go through. I won't go in detail, but if you guys want to go to the gold column on the bottom, then just look at the year-end totals. So as a refresher, the city's plan is self-funded. What that means is the city, we look each year with an actuary at projected claims costs and target where we think those claims are going to be based on a number of factors. And the city sets a funding rate based on how much they think the plan is going to cost. So throughout 12 months, based on the city's enrollment, that's about $19.5 million. Just to give everybody an idea. Of that $19.5 million, $932,000 for the year went to Cigna to administer the plan. So I always like to hit on that. When you're self-funded, you're really paying Cigna, or whoever the carrier is, it's Cigna in your case, a fee to administer the program. If you're fully insured, which is what a lot of entities are, you pay them that whole premium. If the plan costs less than that, they made money. If the plan costs more than that, they lost money. Kind of the same with being self-insured. The difference is the city retains that money when the plan finishes positive. So about $932,000 out of the $19 million goes to administer the program. So pretty small piece. The next piece is what we call stop loss or pre-insurance. And that's our protection against anybody that has a catastrophic claim. I always use the example of a premature baby. A premature baby that's born that could be in the NICU could easily be $1 million to $2 million claim. So the city pays the first $300,000 of any individual's claims, and anything beyond that is picked up by the reinsurance. That reinsurance coverage costs the city about $1.5 million last year. If the city wants to take more risk, and say, hey, we want to take $500,000 on each claim, that premium goes down, but you take more risk, and vice versa. If you want to take less risk, that premium goes up, and the insurance carrier pays it earlier. So that costs about $1.5 million for the year, and we'll look at some of what they paid out on that. This year, it kind of varies year to year. Some years they make money, some years they lose. So medical claims is our next column. That's your claim for anything except basically a retail pharmacy, retail mail order pharmacy. Medical claims, we were at just shy of 15 million, and pharmacy claims are about 4.8 million. So when we add our claims together, that's about $19.8 million in net claims. That's actually after the stop loss, which we're going to talk about in a second. When we put all those together, and then if you'll see a line pharmacy rebates. So those are rebates that are paid generally on higher cost brand name drugs. So if you see it during a football game or a golf tournament as a commercial, there's probably a rebate being paid on that drug. The city got back about just shy of 1.1 million. So when you put all that, and obviously the red is not good, when we put all that together, the plan last year went about $1.6 million over expected costs. Just as a reference, and then I'll hit some more, if you take a look at the next page, that's the summary for the prior year. The plan in that year finished positive about 1.3 million. So if we go back to the first page, I'll hit a couple of things and then we'll kind of talk about what's going on. If you look to the little summary cheat sheet on the right, you'll see a couple bar graphs and you'll see net, medical, and pharmacy claims. So we had a 20.4% overall increase in medical claims last year. Pharmacy claims went up 9.1%. So if you look in the box down below that, when you average those out, because they're not a one-for-one weighting, medical is a lot more than pharmacy, as you can see. The overall claims costs went up about 17.5% last year. So the first thing I'll tell you on that, and then we'll talk a little bit about why, is we took all of our clients that get claims experience, we dump into a system called NAVMP. We dump all the claims, and we ran a report for last year. And I don't remember the exact number, but it was like a 28.5% increase across all our clients in claims last year. So you look at that and say, well, Clearwater's a little bit better than that average, which is good, but obviously claims are up substantially, which we're going to talk about in a second, kind of what's driving that. Your enrollment was down a little bit, 2.3% decrease in enrollment. I know I haven't talked with Jennifer and her team specifically about this, but pretty much every client that we're at right now, they have vacancies. They're looking to fill positions. So when that happens, people have waiting periods, so that tends to lead to lower enrollment. I imagine you guys are experiencing some of those workforce challenges. So that's probably the big driver between enrollment being down. If somebody leaves, when you fill that position, even if you filled it right away, it's a little bit before they're on the insurance because of the waiting period. So then if that position is open 2 months, and they hire, it might actually be 4 months that you didn't have someone on the insurance. So that's probably what's driving the decrease in enrollment. I'd like to point that out because it's not people saying, oh, I'm jumping off the plan for some reason or another. It's probably those open positions and that time lag affecting that. If you do look, you will notice that if you just kind of eyeball those numbers, December was actually the highest month. So we really got hit pretty hard in the month of December, almost $500,000 over budget in December. So overall, in the kind of middle left, basically we're 8% above kind of the budgeted set cost for last year as we finish the year.
Do you have an idea of how much of that increase was related to COVID claims, or is there a way to track that?
We're going to talk a little bit about that. I will tell you, Steve, on the, I'll say this without getting political, but I'm sure if you've watched the news, you've heard people talk about hospitalizations for COVID, right? Like all you have to do is turn on the news and hear, one side's, the left and the right are fighting over what defines a hospitalization. I'm not getting into that argument, but what I will tell you is that those same concerns, Sean went in for a knee surgery and got COVID while he was in the hospital, and then they're saying, okay, I was a COVID admission. Was I or wasn't I? Well, those same concerns are actually trickling to insurance. Because now the hospital's coding things as COVID. And what we have is, I'll say it this way, I don't know how accurate some of the data is in terms of what part is actually COVID and what part is the other stuff, because all those things are going on. The other thing is with the original, which was it ARPA or CARES Act, I can't remember the first one. I think it was the CARES. Which one came first?
Cares.
So with the CARES Act, there was also a lot of stuff that went to hospitals towards treating COVID. So I'm not going to say that any hospitals were unethical, but the concern that's been brought up is, were they incentivized to code something as COVID to get more government reimbursement? So last year, I don't have the 2021 numbers. The year before, globally, we saw COVID be about a 5% average percentage of cost on the life. But in 2020, what happened was that 5%, you almost didn't feel it because there were a lot of other things that dropped off. In 2021, we've got those added COVID costs, and we'll figure out what the actual numbers are. But most everything else returned to normal. So in 2020, it wasn't an extra piece of the pie, it was kind of part of the pie. It was sort of diminished by other savings. 2021, it's like on top of all our regular costs. And we'll look at some of it. The prevailing kind of industry thought / concern is that a lot of what we're seeing is delayed as a result of delayed care because of COVID. So things that were put off, things that maybe got more severe, especially in the cancer realm. There's a lot of, and they're still putting all the data together, but there's a lot of concern that they're finding stage 3 and stage 4 cancers because somebody put off a colonoscopy in 2020 or a mammogram. They haven't got to a point yet where they've correlated all the data fully together, but I'll tell you, like almost everywhere I go, we talk about that. Somebody in the room goes, I know so-and-so that skipped their mammogram and now they found stage 4. You know, so you hear it anecdotally. We're still waiting for them to kind of finish the full data analysis.
And I know Sean's going to get to it, but our catastrophic claims are up. And that's not necessarily COVID.
Yeah.
No.
Yeah, and the question, Jennifer, which we'll probably never be able to answer, is like, if you had somebody with a heart attack, did they maybe put off an appointment that would have caught you? You'll never know. And the real answer is there's probably some of that, and then there's probably some that's completely unrelated. That's more high.
Feeding off of what both Jennifer and Steve said, would you attribute the increase to physical or pharmaceutical increases?
Well, if you look at, the best way to look at that is just look at that chart kind of in the middle. Right. So 20.4% was kind of the year over year on medical, 9.1 on pharmaceutical.
You see that rising again?
So pharmaceutical has been rising at rates in that line almost year over year. You guys, the year before, if you look, your pharmaceutical was up. If you look at that same cheat sheet, your pharmaceutical was up 24.8% year over year. Different things driving that. Cancer meds are probably the biggest single category. Diabetes is probably the second, and we'll talk about that in some of the subsequent pages.
I know we had anticipated an increase in cost for last year too.
Yeah, and I think, if you look at the second half of the year, and this is consistent with a lot of our groups, I think the prevailing thought mid-year last year is a lot of actuaries thought that we had got the bump in the first half of the year from kind of those COVID catch-up, and that it would really trickle off the second half of the year. It seems with most everything that has not been the case. It's actually continued to go up.
I think just because some of the second wave again.
Yeah,
some of that.
You're having added cost with that. The other thing to remember when we look at, projecting forward, we're always looking at medical inflation, right? Medical inflation, the last 5 years in the state of Florida has been better than it's been, know, 15 years ago, but it's still 9% a year. That was when regular inflation was, Jay probably has a better number than me, right? 1%, right? So now the reason I say that is, what did they say in December? 7% regular inflation. So it doesn't necessarily correlate that you know, immediately adds on, but that inflationary pressure is definitely going to hit the medical market, as well as there's major staffing shortages in medical care right now. So all those things are going to drive up that. They also, you know, there's supply and demand for the care. If the doctor's offices are short-staffed, they can't get as many people in. Do they miss somebody that, you know, do they catch them? And I will tell you a personal story. My wife ended up in the emergency room back in late November, and it was solely because her doctor's office, they were so busy, they just could not get her in. That could have been an avoided visit, but they just did not have the availability. They apologized and they said, go to the ER. You know, so I think there's a lot of things putting pressure kind of on the system right now. The question is, how long does it sort of take back to get back to a more normal level? So if you guys want to go kind of the third page back after the agenda, just want to give you an idea, because we haven't seen some of this in the past. If you go to the far right in the bold column, these are all your claims that went over stop loss. So just to give you an idea, it's about 1.7 million that Cigna paid in stop loss. And you look at if you look at the bottom, remember that you paid them 1.49 in premium. So again, if we looked at this for last year, pretty much from what I remember, they made money on you. This year they lost money. Next year it could be the same. The good news about stop loss increases is stop loss is, if you remember, you know, it's a very small piece of the pie. So even if we get a 15% increase on the stop loss, that doesn't directly correlate to the plan. They also pool it for all their groups, so it's more of a pool product. But if you look, just to give you an idea, you see some of those numbers in the December column. You had a $1.1 million claim. You had a 662, 520. We haven't seen that on your plan in the past couple of years. Not that we've never seen it before, but we've generally seen one. You know, this year you got 5, 6, and then you have a lot of other ones still in the high $100,000, $200,000 range. So that's largely what's driving plan costs.
Now,
So, yep, go ahead.
just one question, because I'm trying to remember if you had said this in a previous meeting. If someone's involved in the stop loss for whatever the medical claim is, and does that stop loss continue to the next year, or do we do another $300,000 worth of cost
It
for next year?
resets January 1.
So it does reset each year. Okay.
Yeah. Resets January 1. On your contract, it's based on the date the claim is paid.
Okay.
So, you know, there's ways to do it based on the date it occurred, but sometimes that a claim comes in 6 months later and it's a whole nightmare. So yours is just based on not necessarily the date the claim paid, but when it incurred. You know, we saw with one of your claims, it had actually incurred the year before. But when you have a claim of that number, you know, they negotiate with the hospital, they fight it down. So it can take a while for it to catch up. So if you guys go to the next page is a graph just of the claims per employee per month. You can see kind of that upward trend. But if you skip that page and the next page, there's one that says top 10 physical health conditions. I really want it's page 5. We just cherry picked some pages. We didn't want to bore you guys with the whole report. And then page 6, this is kind of what I wanted to just hit on as far as cost drivers. So regardless of all those catastrophic claims, this is what's really important to kind of keep in mind. Your highest cost condition on the plan is diabetes.
So I'm gonna jump in there. for a quick second, because I want to make sure that you all understand, like, we pay attention to this stuff. We don't just bring you bad news and like, claims are up, so we're going to need to increase premiums. We try really hard to combat that kind of stuff and identify our problems. It's been diabetes for since I've been involved with the plan. We just rolled out the Amada program, which we've had a great response to. I mean, a better response than other organizations have had, but that is specific to diabetes prevention, and it is an amazing program. A majority of us tested it just so we could speak intelligently of being users, although I'm not a diabetic yet, I'm not, but so, you know, just so we can help educate people. You know, we send out our emails, we do that kind of stuff. We know that email readership is like 40%. Okay, so that's the really important part of this committee, is to make sure that you all know about those programs and then also help tout them. I know people don't want to do that. There's no cost to the employee, and there's actually no cost to the plan unless it's successful. So I mean, like, so it's an amazing program, and when you have numbers like this and claims like what we have, I mean, like, these are the things that we need to do versus just saying we don't want to do more premiums, right? Like, we need to take an active role on prevention and then maintenance too. And like I said, so we're doing our part in trying to find programs to match our problems and then get those to employees at an affordable rate. This is free. It doesn't get more affordable than free. So, you know, we need the help in getting those words out and the comfort. And I'm also telling some of the people who are comfortable that have signed up for it to, you know, be champions of that in terms of their success as well. The program also, in terms of the second one, which congestive heart failure can be for a lot of different things, but it also, the Amada program combats obesity, high blood pressure, all those things. So those are, you know, two components of that program. So, you know, again, it's not just about claims, it's about having a healthy workforce and making sure that we have those programs for our employees. So any help that you can do and suggestions on how we can do a better job, and you can email, you know, we're having a lot of talk about text messaging because people read their text messages. But then we're concerned about employees being upset, like, you gave my phone number, you know, kind of a thing, but we want to get these messages out because of how important it is, and then we can take control of a lot of this, you know, majority of this. So, okay, sorry.
No, and I think that, so if you guys look on the line down below, I'm a picture person, I always go to the picture, but if you look at the table, you'll see the plan paid about 1.2 million for diabetes. Only 133,000 of that was an actual like medical claim. So 1.1 million of that was a pharmaceutical. And there were 211 individuals that are in that diabetic category. So to Jennifer's point, the Amada program is a pretty amazing program. A lot of the HR staff tested it. It is largely targeting more pre-diabetics than actual diabetics. They actually have a program for people that are already to the diabetic state that they've been rolling out that we may look at for upcoming years. The nice thing about the pre-diabetes program is it runs through at no cost to the employee because it's considered preventative care. They're still working out some of the things on the other. But when you read a lot of the research, what they say is, so think about this, for every individual in your population that's diabetic, there's going to be another one that is pre-diabetic and does not know it. And so the group of individuals in this category, think about the fact that there's, you know, probably at least another 200 some odd individuals that are in that category where maybe we can keep them from ever getting to this. And that's what the Amada program is largely about. So to Jennifer's point, the more that you guys can do to promote it, it's a really, really cool program, I think, in the way it works. I think there's a lot of discussions out there about what the future of wellness programs look like. They're definitely changing. Amada is more of a virtual program, but a connected virtual program. So you get a digital scale, you have a health coach, more on your terms. It's not like you need to go to the clinic or you need to come to HR to meet with the coach. You get to do it on your terms. I think you'll see more of those type programs in the future. There's plenty of them out there, but we go through a lot of work really like trying to vet them and say what makes sense, because we'd rather have a couple good programs for the employees instead of 40 and you go, I don't know what to pick, you know, but this is where we know we can make a big difference. So if you look down, and then I'll show you some broader categories on the next page, Congestive heart failure is your second highest overall category. And then on this page, your cancers get broken down. So the malignant neoplasm is cancer. Breaks it down by different regions or parts of the body. So breast cancer, you had 21 claimants. That cost the plan about $783,000. You'll notice not much in pharmacy in that. There's still a lot of costs tied to the medications, but what's happening is the hospital or the doctor's office is actually administering that. So it runs through the medical side of things. So your real pharmacy costs are probably higher than some of those reports show. But the way it gets coded, it comes through like a medical claim. Your inflammatory bowel disease, this is one with psoriasis that we've seen, and psoriasis is on your list, really jump up. It's not that there's more individuals with the condition than there were in the past. They're treating it differently. They're using the Humiras, the Enbrels, which can be $6,000, $7,000, $8,000, $10,000 a script. Where originally it was only for rheumatoid arthritis, now they're using it for psoriasis, for ulcerative colitis and Crohn's, some of those. So that's where you see on the inflammatory bowel disease about $600,000 in pharmacy spent. If you go down, psoriasis is on there as well. You had 63 skin cancers, but what you probably had in there was probably 1 or 2 major ones, and the rest were probably your very small, done in a dermatologist's office, a basal cell, something like that. But you had, I think, 1 or 2 that was actually to the melanoma stage and more serious. So again, skin cancer checks in Florida. That's another thing we really, it's preventable, or it's avoidable, somewhat preventable if you put your sunblock on, but it's definitely something with regular care that you can get ahead of it and not have an issue.
So another opportunity to plug. Remember, we have the Motivate Me program, which pays you guys, girls, things that you should already be doing. $200 a year, and it covers dermatology. You know what I mean? You can get paid for doing that. Mammograms for women. You know what I mean? So again, please help in terms of promoting that. We have less than 50% of our employees that participate in that. We're doing things that you should be doing. We paid for it. So again, those are ways to combat claims and help take care of our employees. So we have a Thai department. We've sent that out. We know who doesn't appreciate the programs yet, and so where we have room to make improvements, and again, I think that's where this committee really comes in place, making sure that you understand those things. It's $200. Very easy to get, and in any form that you want it. You can, not without cash. It's not cash, but you can get it using debit card, Publix. I mean, there's 100. So
And they don't take the tax out of your paycheck, like.
Right. So, well, no, we do. It is taxable. No, it's right.
It's not, because it goes through Cigna.
And yeah, so
Gift cards through
correct.
Cigna as opposed to Cigna.
Well, that's right. I feel like we do. It's in the redemption
No,
report.
not on this one. Because the gift card comes through Cigna, not the
It's in
Cigna.
the report to payroll, so I think we do, actually.
Yeah, we have a redemption report, yes, we can take it out.
But even,
Tell the employees that.
yeah, but even still, so instead of 200, you get $190. And
I
you
always tell people when they say that, I say, well, taxes come out of your paycheck and you still want that. So why would you not want a gift card with taxes coming out? Like, nobody says,
but it gets in
oh,
people's
it's not giving me
minds.
my paycheck, it's taking taxes out. That's always my argument.
Going back to the medicines up there, and I see the 3 biggest pharmaceuticals over here, obviously diabetes, psoriasis, and IBS. And those are the biggest new medicine commercials that you see on TV. Some of the new medicines, I know Humira and stuff like that is being repurposed for other things, but there's a lot of other new medicines. Are you seeing more claims and more cost increase because of those people getting on those new medicines for those?
In the diabetes category, absolutely, because there's a new commercial for a new diabetes drug almost every day. And the challenge with the diabetes ones, and I'm just not an expert, I've just learned this from listening to experts talk over the years. Historically what you had people on metformin, which was very cheap. And my understanding is most people, though, when you took that, you had to test a lot. So it was an inconvenience to be testing all the time. and doing some of those things, and it maybe wasn't as effective as some other things. Well, now they've come out with a lot of these higher cost medicines. You know, instead of a $10 metformin, we have $1,000 a month XYZ drug, but you only have to test once a week, or, you know, you only have to go do these things. So from a convenience point of view, it's greatly improved kind of people's, you know, lack of being tied to testing all the time and doing some of those things. That's the good news. The bad news is we've replaced a $10 drug on your plan with a $1,000 a month drug. That starts to add up, you know, if you get 200-300 people doing that. So Cigna, or any of the carriers really, they're pretty good in regards of putting pretty strict sort of step therapy requirements or trial requirements on the providers and the member. Meaning, if I get diagnosed today, I can't go in and just start on that $1,000 a month drug. They've got to show that I tried the first one, it didn't work, you know, and have a reason for it. But the doctors have gotten pretty good at finding ways to weasel around, you know, some of those requirements. They know what to write to get it approved quicker.
I know some of these medicines are brand new, so the data isn't really out for farther along on how well they do. But that'll be interesting to see if some of these new medicines that come out tend to control the diabetes better to help control the cost of long-term care.
Yeah. No, I think we'll see, and you know, there's a lot of, you know, you listen, you know, there's a lot of talk around, you know, do we have more nutritional counseling available on plans? Some of those things, because a lot of this is tied to diet, it's tied to exercise, right? Can we prevent some of these things? And if you really start researching foods and, you know, what's going into food these days and all the processed food, you know, there's a lot of tie to that. You know, so how can we help employees with on that educational side? Omada does a lot of that.
We also have a nutritionist study for the diabetes, such too, consultancy, right?
Well, we have
Besides
numerous, yeah, we have a couple different plans or programs along with it. So we have the Food Smart, which comes with you know, dietitian, and that's not just specific to diabetes. That program is also really neat because it has different you know, diets and recipes based on condition, of which diabetes is one of them. But they have all kinds of things in there. So we have multiple programs available in terms of nutrition and stuff to, you know, help aid that.
And no cost to the employee, correct?
Correct.
So I think,
With
you know, for this committee, because all your guys' departments are different, but you know, what we want as much as possible is different feedback on ways to get that message through.
You know, so Food Smart is the one that, because they're a partner with Cigna, they asked if they could do text messaging. And we told them to hold off on it right now because I don't want to have any negative association with that stuff, right? I want to get the information out, but I don't want people to be like, how did they get my phone number? Now, they're a partner with our health insurance, so by enrolling in the health insurance is how they got it. There's no selling of information or anything like that. It's, but we wanted to have more of an opt-in versus an opt-out, you know, type of a thing. And so we're working with them on that. But, you know, so and it's something for you guys to think about too, because we have the tools and the capability available to do text messaging. I'm just not sure how well that would be received. I mean, it is a better way to communicate though.
I'm just curious, what do you guys think? Like,
I think you might be right on the opt-out type of thing because people will have, well, why am I getting sent this text message as opposed and not really paying attention as opposed to another.
But the problem is that they don't read the emails to opt in.
Yes. Now I was going to
so
say.
we stay in this, you know, stay in this circle.
And unfortunately now we just gotten rid of the payroll pay stubs. It's all got electronic. Because otherwise it could have been like a page that attached to your payroll sheet. So now we have to figure out a different way of that.
You know, we do time clocks, we do the bathroom stall, you know, and that kind of stuff. But text messaging seems to be like the wave of communication. So, you know, at some point it's something that we might end up doing just because, you know, people aren't going to read their emails and we obviously can't do face-to-face stuff on you know, as much as we want to. You know, that's just another way to communicate. So just be thinking about that.
the other thing is you can always send an email to everybody and say, starting next month, you're gonna get text messages unless you write us. And now, I know a lot of people won't read it, but at least you die. I don't know. I mean, I get unsolicited text messages now on my cell phone. And I think it's just become the way of the world. I was talking with somebody the other day where the biggest thing, I don't know why Apple and whoever, why they haven't added something where you can mark a text them, right? Because that's my problem. Somebody texts me, I read it, I'm in a meeting, and then I totally, I get 12 other texts and it goes to the bottom of the list. So why they don't have like an unread option like an email?
Yeah.
How many people in the city, what kind of percentage of people do we have that are actually participating in Food Smart? Is it very low?
It's pretty low. It's growing, but it's pretty low. I don't remember what our stats were. I know, just because we just got the email no matter, we had 43 people that signed up.
Okay. Well, and that's actually pretty good, yeah.
It's a fantastic
And
start.
actually,
Yes.
wasn't it 100%?
Yeah.
That was what was amazing, is 100% of the people that did it, they were eligible and they all signed up. So that's pretty.
So we're proud of that stat.
No, that's really good, actually.
But obviously want more, Do you have a question, Corey?
Just the,
Usually good.
does the motivate me, did that continue this year? I guess? Okay,
No, that's okay.
so my question is, did you see an increase last year? Because after our meeting, I said, what is she talking about?
Sure.
I went over there, since I'm in CID now, I went around, and I know for a fact, everyone I talked to did what they did, and they were all thanking me. And then I sent Slaughter an email to send out, and I was curious. I know that I can account for at least probably 10 to 12 people. So my question was, did you see a big jump in people doing that at the PD after our last meeting?
Yeah, so we saw a jump, not big, but we did see a jump. Police and fire still are on the bottom in terms of participation. And we do it by percentage, you know what I mean? So it's not like,
Right.
you know what I mean, to keep it fair, right? So there's room.
Both Chief Slaughter and Chief Dollars, I was in communication with them. They both sent out that gatekeeper form so that they did not have to go to the employee health center and they can use their life scan.
Yeah.
So that
Yes.
information was sent out to all
Yes,
of those.
So we did have an
employees.
increase, but there, like I said,
and maybe a couple more months before you see an increase, because we just had our physicals in October.
Sure.
So we're slowly kind of getting people back onto that point now.
yeah.
And then the other thing is,
But thank you for that, because that's fantastic. So like I said, so yes, be happy, we did have an increase. It's just there's still.
so the other thing that the city offers that you'd be surprised that people have no clue what I'm talking about is ND Live.
Yeah.
And so I don't know if you guys all need to come up with graphics and create a poster and put them all over where they belong, or just keep relying on email.
Well, and like I said, so we do the bathroom stall, you know what I mean? Because you should have undivided attention there. So like literally we put flyers on the back of the bathroom doors. And that should be over at the police department. Well, it should be in all of our buildings. I don't frequent bathrooms to check for it, but I know that they're in here, so if you use the bathrooms in MSB, you'll see that there. So we do that. And then also like time clocks and stuff like that. I know I don't have that, but we have things posted as there as well. So those are the other types of communication. And then we're also hoping that, supervisors are having those conversations with employees during, because their meetings or staff meetings, however that is happening. So those are the tools that we have, and certainly open, to more. And then obviously we have our weekly email. We have our website that lists all of our programs and what's happening now, that we keep updated weekly. So, we're certainly trying, but always open for additional. And like what you're saying is proof in terms of like the readership, of which we know what it is 40% on emails. And so we
Most
know that's
people didn't
not.
believe me until they logged on, and then they started saying, "Oh my God," and I was like, "Yeah, I agree."
Yeah.
But then I tried to spread the word, and like I said, I sent an email out with my example of what I got. But I know the third floor did it. I think that's where all your increases came from, but there's the second and there's the first floor. And I think they just didn't have someone to directly relate to and kind of guide them through the process.
Great.
And then next thing you know, they just thought about it and off they went. They never followed.
Yeah, and we are hoping as COVID stays on a downhill trend, that because our wellness person left Cigna, and so we're in the process of recruiting for that position again, that they can do more out in the field, kind of in-person meetings, which will help a lot. We haven't been able to do that because of COVID, but we hope to be able to increase that as well, because then you have more of that personal interaction here. I'll roll you, you know what I mean, like that kind of stuff. So we hope to get back to that.
Joe, can you email me in my personal email a copy of the gatekeeper form so I can have that over to our union president? They can keep copies of that in the union hall. That way, that might be a better way even to get it.
Sure.
That way we can actually have them at the union meetings, so it can be in front of our members when they're there. Thanks.
Sure thing. So if you guys want to look at, it says page 6 of 18 on the bottom, just lifestyle conditions. The difference with this page from the prior page is all your cancers and a couple other conditions, they're all lumped together. So if you had, on the prior page, you might have had, joint degeneration of the back and knee as separate categories. They all get lumped together in this. So this gives you probably a slightly more accurate snapshot of the broad categories. So cancer, when you look at it, all the cancers together, cancer is your top cost driving category, over 2 million in claims. Heart disease and stroke, over 2 million. So think about 15 million in medical claims, and in these two categories, you have about 4.5 million just in those categories.
Is cancer one of those situations where things are happening in the doctor's office, so maybe the pharmacy claims are actually going towards medical? Because a lot of the cancer costs, majority of that is chemo and stuff like that, and I'm not seeing that in the pharmacy.
Most of those are going in a facility probably, so it comes through as a medical claim. Yes, that's why the cancer medical cost is so low. And then you look at diabetes, asthma a little bit. You look at some of those and you see pharmaceutical is the driving cost factor in those. But if you look, as we look and say, what do we promote? What do we structure and motivate me around? This is sort of like what kind of guides us to say, okay, cancer screenings, some of these things, those are the areas we want to monetize. I think as you look at, the joint, it's always been a top category for all of our clients. As public sector entities, we see higher ages than private entities. But, if you look at obesity and some of those things, it has a direct correlation and impact, to the impact on your joints, right? Excess weight impacts your joint. And then you guys also have, you guys in police and fire, even in public works and some of those, you're in jobs that are not necessarily that friendly on your body.
We got a question from Gina asking, any thoughts of bringing back Weight Watchers? Seems like a lot of people had success with that. I believe they have a program for diabetes.
Yeah, so I think my initial thought, and you guys jump in here with any of this, I think the one thing where I hear complaints from people on Weight Watchers is it's very specific sort of to Weight Watchers, right? They have their own system and some of that. I think as you look at the like the Omada program or some of those other programs, they're not structured around, like, I think Weight Watchers is a point system still, is that right? The big problem when we look at a lot of those very specific programs over time is the minute individuals drop off that program, like, they don't know how to eat, right? And I don't mean that in a negative way, but they've been used to this point system and then they kind of get away from that. So I think the difference with like Omada is it's really designed around, there's a coach working with you that is trying to help you if you go to Outback Steakhouse or if you go to this, figure out how to structure that all. So I personally like those programs that are not tied to you buying a line of products or some of those things, because I think the more important thing is that somebody learns how to go around the grocery store and shop much more than they know how to buy, and I know Weight Watchers, there's some of both in that, but a lot of times employees with Weight Watchers, we get complaints about either the ongoing costs or kind of the complexity, but it's definitely something we can look at. It comes back to that though, how many programs do you end up having? Do you have a bunch of programs to do more people find appeal with 20 different programs, or is it better to just have one and kind of guide people and say, that's where we look for your guys' feedback on that. The next page is just your top facilities. I just always think this is interesting. There's not a whole lot you can necessarily do about. They're mostly daycare, but it just gives you an idea where your guys' people are going when it comes to hospitalizations. Just kind of interesting. So what I want to jump to next, if you guys want to look at the timeline, we've had some discussion prior to this meeting. If we were to just say we had to set our rates for a couple months ahead based on the claims right now, actuarially, that would probably come out somewhere in the 12 to 15% range as far as increase needed. Now, we're quite a bit away from that, from actually setting rates. So we'll see claims could stay the same, they could get better, they could get worse. We didn't bring a full projection for this meeting because it's so early. A big component of that is medical inflation. You know, when you start projecting for 2 years of medical inflation, it can make it look long, but that's probably somewhere where the projection would land right now if you just renew it as is, no changes. Not saying that to scare anyone, just trying to set kind of expectations of what we're going to be watching over the next 6 months in that regard. So with that, you know, looking at a couple of things, it has been a while since you guys have bid. You know, we did talk, it's good to bid the contracts periodically. I'll say something before we say that. When you're self-funded, some of you all remember, and you were here back when we were bidding fully insured, and it was like, hey, this rate's 2% lower, and what are those benefits? When you're self-funded, a lot of that goes away. Right, the projection is not really going to change because what we're largely bidding is the administration and the reinsurance. And then we're looking at discounts on the claims. What I do know from having done a lot of bids, but we'll still do a bid for you guys, is that discount-wise, the most competitive carriers are all pretty much in the same line. Why do I say that? Because I don't think when we bid, somebody's going to come in here and say, oh, we can get you 10% more off your claims costs. Because they just, all the hospitals talk, they negotiate with all of them. Everybody's pretty much in line. Pinellas County just bid last year. They left United and went to Cigna. So they just kind of went through that process. So we know Cigna's rates are extremely competitive in the area, and nobody's going to come in and lock them out, you know, in terms of just network discounts. There could be some things that somebody would offer, but anytime, you know, you guys historically, the last 6-7 years, we've had low single-digit increases. If we're looking at, you know, as of right now in that 12 to 15% range, going in front of council, especially you may have some new council member, you will. By then going in, somebody's going to say, well, did we look at the market? So we figure since it's been a number of years, we will do a bid this year for the administration. You know, just looking at self-funding, looking at what the market has. That timeline, it's sort of a rough draft at this point. We're going to meet with purchasing to kind of finalize some dates, but this is kind of a timeline of when we would have the bid released, when we'd be looking at. What we're going to do while that goes on, do you want to jump in?
No, go ahead.
Okay.
I'll jump in when you're done.
What we're going to do while that is going on is we're not going to do anything different as far as the committee in terms of still looking at claims, still looking at cost projections going forward. We're going to kind of operate with the committee as if for now nothing's changing, because we don't want to put everything we're doing on hold just because we're doing this bid. So, did you want
Yeah,
to
so what I just wanted to say, and this is part of why we're meeting so early this year and starting this, is to make sure that you guys have the information, and also as like confidence building, and that we don't just like take that things are not right, right? And so we have the programs that we've been, you know, rolling as a proactive measure. We're doing the bid stuff to make sure that we're competitive. We're looking at all those things. We did an RFP and did a bid for broker services. That was completed last year, of which, you know, Gary Group came out as the successor on that. So we're looking at everything we possibly can to control what we can, right? And then put programs in place for things that we can't, and are always open for suggestions for other things that we can do. But when we're looking at hefty increases, like we have potentially facing us with this kind of news right now, that's why we're starting the education process early. And we also are starting it early because we have time to, have some rewards in terms of getting people active in these programs. So that's the, I just want to make sure that that's being communicated. That's what we're trying to do. Nobody likes to hear about insurance going up. It's infuriating to lots of people, to most people. And so I want all of the message to be done in terms of all the things that we're trying to do, all the programs that are available, but then also in preparation that, if we keep going this way, it's a double-digit increase.
Sure.
It's unfortunate.
So again, being self-funded, all our money that we're paying in goes in the pot, all the money that we're paying out goes out of the pot and such. And if I remember from previous years and meetings and such, we talked about new carriers, say United or Pharmaceutical or whatever it is, that for the most part, what we were looking at was the administration cost on it was the main difference. And previously we said that's pretty much about the same across the board, maybe $50,000 a month difference, but pretty much the same across the board for administrative costs. The biggest issue that take into consideration when we're bidding, and this is something that we heard a lot of outcry about when we went to the lesser affordable health care plan of Cigna, which decreased our costs and such somewhat.
Talking about the more limited network.
Yeah,
and we tried.
but it was such a nightmare trying to find doctors. Like they only have one allergist in the whole county and things like that. That was a nightmare.
Yeah, so in that process, when we do the evaluation and all that, there's going to be a number of things we look at, but one of them is going to be network disruption. So Cigna will give us a report of every provider that's seen in their tax ID, and any carrier that bids is going to go in and say, yes, that doctor's in the network, no, they're not, and essentially say, okay, it's a, if you go to XYZ carrier, you can go, but it's only a 90% match. So that's a problem. The other thing we do is we ask them to reprice claims, which is where they take all the claims you had in the last year and say, if you were in our system, here's what that would cost. I will tell you that there's, and then we'll just ask them overall about their network discounts. The reprice is probably the one area where carriers can get slightly sneaky. So some of them exclude certain categories. They're like, oh, well, that's lumped together with us, and they try and make their numbers look better or worse. So that's something we'll work through. That's what we're here for, is to kind of do that. We just know, the big thing is you have, if you look at who a lot of the groups around you are insured with, you know who the big players are. And you know that there is some safety in the sense that they've all done that same claims analysis, and they've kind of ended up where they've ended up, and that's something that we take into consideration as well as we do that.
I remember years ago, and I think it was back when we had United Healthcare, and then it went to Humana briefly. And Humana said, oh, we're going to give you this lower price over here. But then the next year they increased it a lot.
Oh,
We
yeah.
only kept Humana like 2 years, then we got rid of them. I remember that.
You had them 1 year. It was a rough
Yeah,
year.
yeah,
It was like
that
right
was
when
it.
I started, I remember it. And I think Humana, the big challenge they had, you were fully insured back then. And they said they could do a lot of things that they couldn't do.
And their customer care was a nightmare.
Correct. And
United Healthcare was bad for paying the doctors, but they cut
Yeah.
customer
And I
care.
think if Humana had come in and just said, this is all we can do, it wouldn't have been as bad. But it was still, it was bad. And I think overall you guys have had pretty good experience with Cigna. I mean, nobody loves any health insurance carrier all the time. If you do, they're probably paying too much because they just approve everything.
Before the benefits committee, I dealt with United Healthcare and Humana and Cigna. Cigna was the easiest by far to deal with on
Yeah,
claim
we've had
wise.
a very good run with Cigna, and just, my time here, in terms of they're responsive, we don't have a lot of claims issues. in terms of like problems type of stuff. And so it's not, we're not doing it because we're not happy. We're doing it, we want to make sure that we've done everything we can, you know, in terms of making sure that we've got, you know, a fiscally responsive plan, right? And that we're controlling costs where we can. So.
That's the biggest thing. Yeah, obviously, Steve. And you'll be looking at like changes in deductible and out-of-pocket max and that.
So really, so that's where kind of my conversation about we'll kind of be concurrently doing two things. As far as the bid, so remember you're self-funded. So let's say you make your deductible, make a random number. If I make my deductible go from 500 to 1,000, right? It in theory should not be any different between United, Blue Cross, Cigna, and Humana if you do that, right? It should be the same impact because I'm still going to the doctor either way, you know, no matter what the carrier. Now, when you're fully insured, like what you guys had in the past is, you know, XYZ carrier say, hey, if you take your deductible from 500 to 1,000, I'll give you 3% off. And the other carrier says, I'll only give you 1%. Because it was their money, you guys said, okay, we'll go with the one that gives us 3% off. When you're self-funded, we have all your claims. We're just gonna run all those claims over the last 2 to 3 years and say, okay, if you had made that change, it would have saved you an average of 1.5%. We don't care what the carrier says it's worth because we have your actual claims. That's the best estimate we can make. So from the bid point of view, Steve, what we'll probably do is we'll just say, assume you're matching the current plan as is and tell us if there's anything you can't do, right? So an example is maybe you have a copay on, you know, an imaging type service and they say, oh, the only way we can administer that is deductible and co-insurance. We want to look at that, but we're not really worried about them being able to match because most of the carriers on group size, they can just match. So what we want to know is, hey, for what we're getting now, what are you going to charge us for admin? What are you going to charge us for reinsurance? And what is your network and network discounts look like? And then what kind of stuff are you going to add in? Like Cigna gives you the wellness position and some of those things. You know, what else can you do in that regard? That's really what we're asking for. So in a lot of ways, it's an easier bid, but it'll be a little difficult in the sense that most insurance companies have not lost much business in the last 2 years with COVID, but they also haven't gained much. So they're all getting pretty desperate. You know, so, you know, somebody may throw some crazy offer at you. And that's where we really have to look though. They can't make the claims any lower. They really can't make the, so it's like, okay, if they cut, even if they cut $100,000 off your admin fees, you know, that's where we all have to look and go, well, is it worth it? Because it's 100,000 out of 20 million. You know, is 100,000 worth it to disrupt every single employee to have to get, you know, reprocess all that, and that's kind of the process we're going to go through.
And that's my one concern. Obviously, we need to do the rebidding every now and then. It's a good thing to do the rebidding. That's just my one concern. Looking at the city in general, they tend to go with a lower bidder as opposed to, so that's I think where we really need to be able to take a look at all these bids ourselves.
And, you know, I can tell you from an HR perspective, I'm certainly not talking from an organizational perspective, but from an HR perspective, we haven't been limited to only pick the lowest by any means. And I have several examples of that from our paying class study to our cultural assessment that we're getting ready to launch. You know, that there have been other examples, our ADA transition plan, and in that, you know, they took the committee, the RFP committee's recommendation. It was not just the lowest. So I understand that, like, that's a reputation, and many times, and Jay can talk better than I could in terms of that, and many times, yes, we do have to go, or not have to, but the lowest bid is what is selected. But from an HR perspective, that has not been our experience, and nor have we gotten any pushback from council when we haven't done that. Like I said, I have all those examples, you know, to say, you know, what we've done.
When do you think about it? I mean, it's all squared away and
we have that draft timeline, which is that page. So I think that's kind of the estimated timeline right now. We have some meetings with purchasing coming up, so it could tweak, but if I had to lump it in, you know, kind of we're thinking that early August we'd be in front of the council. The one caveat with that is stop loss. Sometimes they won't lock in that far ahead. The other thing that could happen with stop loss, which really doesn't affect anybody, is we don't have to have our stop loss with Cigna. We can have Cigna, but have our stop loss with, I have groups all the time that have it carved out. The employees don't even know, because the employees don't even know we have stop loss right now, other than you guys. The only thing that, and this is where some of those discussions we would have more with finance, is when you have it with Cigna, the minute somebody hits 300, even though it can slip through and get fixed, Cigna picks it up and stops charging you. If you use third-party stop loss, you get that $1 million claim. The check has to get cut to pay the claim. Then we have to file for a reimbursement. Within 30 to 60 days, they give the city $800,000 back. So if somebody's $50,000 lower on stop loss, but it's not integrated, is it worth it? No. Somebody's $500,000 lower on stop loss, yeah, we'll deal with the process of manual claims. So it's all kind of that, what is this worth to me? At the end of the day, I will tell you, if 12% was the projection and we go to bid and somebody comes in 10% lower on their admin fee and 10% lower on their stop loss, projection is still 12%. I mean, it might be 11.95, but it's not changing. So that's where this bid is a little different than bids you guys have done in the past year.
Just when you're talking numbers, why does it say here amounts listed on this report may vary from city financials and are subject to change? What's the plus or minus percentage are we talking about?
Oh, negligible. So the reason we have that, so the city, so we get a report that says here's all the claims that were paid in the month of January, right? Well, when the city, let me give you an example. Let's say December 30th, you had a surgery that was $10,000. The city won't actually pay that claim until January. But on the Cigna report, right, because it was December 30th, Jay gets a weekly claims bill. Daily, and then, yeah, right. So like if that claim doesn't hit for a couple days, Jay's report is going to show the claim that he paid it in January, but Cigna's is going to show December. So it's stuff like that. It's timing differences. It's just timing. It's not.
So for the 2020, I guess my question is, I thought I could figure that out. Then when I looked at the 2020, I was curious why it's on there as well.
Just because we want, if somebody in Jay or his team's position goes, Garen Group, I said I had 19.79 million in claims in the year. If Jay runs it and he goes, I get 19.792, it could be because of those small timing differences. So we just put that on there so somebody doesn't try and match this up to their reports and drive themselves nuts, because it'll never line up exactly. But it's not $1 million or 100. It's probably $3,000, $4,000, $5,000 out of 20 million. So it's negligible.
In fact, just this past year, we went back with them and reconciled like the last 7 or 8 years to make sure we were right, pretty much on the money as far as the total claims and the total savings that we got.
Yeah, there's a banking report and there's a claims report. You end up paying the same amount at the end of the day, but you may pay one, in a different month or some of that. So it all kind of washes out. Does that make sense?
So when the bids and stuff come in, we'll also have a better idea of a trending, how our medical and pharmacy costs for this year are trending.
Yeah, I mean, we get these.
So this 10 or 12% may change based on.
Oh, yeah, we hope it does. You know what I mean?
Yeah, we do.
You know, it's crazy otherwise.
Yeah.
You
We
know.
had the year before, we had 1.3, we were under 1.3 million, and this last year we're over 1.6. So based on what we were planning, so I mean, technically between 2 years, we're over 300,000.
Yeah.
So
There's still time, absolutely time for it to change. That's why I wanted to start having these conversations early, know everything, you guys know everything that we're doing, so you can communicate with your people and they have ideas or suggestions, do that, but then also really pushing the programs so that we have an opportunity to make a difference, in those. And so we do focus things the other way because we've had a lot of red months.
And
Steve, I just wanted to let you know too, for 2022, the gatekeeper has changed for Motivate Me. So you have to do the biometrics and you have to do the health assessment, which is online. Yeah, which is good though.
for the
because-
gatekeeper, in addition to your, or is that in replace of the,
No, you have to do
in
both.
addition to physical?
Yeah.
Before you can claim the other ones.
Yes.
So, okay, so for our members that may have already had, say, skin cancer checks, since they're physical, if they haven't done those, do those skin cancer checks not count?
No,
Or
they count.
okay,
As long
They
as,
just won't show you.
once you do your gatekeeper, then the skin cancer checks will.
you don't have to do it and you don't have
In
to go to the
chronological
doctor
order.
in the chronological order,
Okay.
but in order for any of it to be eligible, you have to have that part done. So
Okay, that's.
and most people
good.
aren't, I am not over at all, just because of how it.
Because I know some people had their annual physical in November.
Mhm.
So they've done everything throughout the year, but it doesn't populate that they did it until they do the physical one.
But no, you don't lose it.
Okay, yeah, ours is right on the border because we do our physicals in October, so it kind of makes it kind of squirrely because that's when the Motivate Me changes in October.
Yeah, I don't know, because I'm not that familiar with the site. Does it show those pending, if you do one of the ones?
I don't think so.
I don't think so.
It
Yeah,
won't
I
have
don't
off
think it-
until you do the gatekeeper.
Okay.
Yeah.
We noticed last year when we were looking at it, all of a sudden they appeared when you look at your rewards, so to speak, on there. All of a sudden you'd see the rewards would appear on there, not necessarily you had to do it like submit it. So hopefully that will happen again this year as well.
Any other questions? Okay, well, I guess we will conclude.
Yeah, thank you guys for coming. We'll meet again, we'll keep you posted as we move through
Yeah, I
this.
think because of the claims, maybe in a couple of months, we'll get back together and see how the first, I'm sure, has started off.
Very interesting.